Thank you very much. Thank you, Terumo, for inviting us, and more importantly, getting data for us. It's very important. Doing a registry is not easy, but you guys, spend the time, of course, the finances and stuff, and got this data for us, which is now easier to convince the interventional radiology community that this is something that we should be doing on a regular basis. Thank you to my colleagues for doing the heavy lifting of this for this meeting, for this talk, and I'm going to do the easier part, maybe the fun part too. Advanced cases. So I'm going to show a few cases, and hopefully it can convince you that this should be a part of your practice. I started doing the radial approach somewhere in 2015, 2016. Consider myself an early adopter. I was not the first adopter like Dr. Guimarães and Dr. Fishman, but eventually built the program, and a lot of our procedures done via radial approach. So I'm going to show a few cases here. This is, for all the IR guys in the audience, you guys know that these are the two pelvic arteries, but two different anatomies, right? So if you see, this is a uterine artery, right? Tortuous, corkscrew, right? And the other side, it's a very small artery. So they're two different procedures, right? They're both, all pelvic arteries are not made equal. One is a PAE, one is a UFI. So although they're both, what we consider to be similarly placed anatomical organs, it's a completely different type of, embolization process, how we get there and stuff like that. And then, we often think that, we often say that UFI is a quick one, right? I usually schedule about an hour and a half for UFI, and the next patient is getting ready to come down. So the moment I get access, the nurse knows that in about 45 minutes, 1 hour is going to be done. The next patient comes down. But as you can see in this, and I'm going to show you on more slides, it's different, right? This is a UFI. See the tortuosity of the aorta, see the tortuosity of the vessels. So a UFI, uterine fibroid embolization is 45 minutes until it's not, right? You can have difficulties. And the aim of this presentation is not, not for your routine UFIs. Those are simple to do from the radial approach. And so I'm going to show a case that is a little more complicated, and what were my challenges and how we overcame those with the tools that we have. And coming back to tools, a lot of things had advanced in the last few years. When we started this in 2015, there was a SARA catheter, there was a ProGrade that was not even 150 probably at that time, it was 110, 130, and now we have a vast range of products that are available that you can use for successful cannulation. So it's that UFI, I get radial access, it's a good size artery, I get into the right side, you see on the left side of the picture, and then I embolize that, and then we go to the left side, and you see what we call empty pelvis, right? You don't see any artery there. It's not a common an anomaly, but the more you do fibroid embolizations, you'll see some of these. Okay, so then what do? I go back and do an aortogram, and I see that yes, it's a tortuous aorta. You see that, and you see some tortuous vessels next to it, right? So those are ovarian arteries, right? So few challenges in this case. So there's a lot of tortuosity there, right? And then the ovarian arteries are coming out. This is almost like a PAE now. It's actually more difficult than a PAE because now we're talking about a big aorta and arteries that are coming out virtually at 45 degrees up or 90 degrees up and then going down. So this is a challenge. This patient specifically from a clinical point of view, when, for those trainees in the audience, when someone has advanced age, prior surgery, large uteri, you have to think of ovarian arteries as being, they could be supplying. So look for these things because you will not have a complete embolization. What are the solutions? Always be ready to look for the atypical and have your toolbox ready, right? You need to have this on your shelf so that you can deal with the situations. You cannot, unilateral or failure of embolization in UFI is sort of unacceptable, right? It's an easier procedure. So you should have all these things that you can deal with these problems when they occur. They will not occur too often, but you need to have them. So what tools do we have? We have various catheters and wires now and microcatheters available. So for femoral access, we do reverse curve or MIC or SIM would have been good for this, right? You go, you hook into that ovarian artery and you get it, you're done. But now I'm already committed. I've taken the radial approach, okay? I've embolized the right side, and should I shift to femoral? Yeah, I can. But data has shown that we don't need to shift anymore. There is zero conversion rate from radial to femoral because of this. We have tools now. So you have the Ravi MG1 one catheter, which is mainly for visceral vessels. So SMA, celiacs, it's a good catheter. You see the curve there. which is different from the one on the left, different from the one on the right, which is Ravi MG2, which is mainly used for visceral interventions, for pelvic interventions. Okay, so those are mainly for UFI and PAE. I've interchangeably used this catheter sometimes depending on the angulation, but they're good catheters. The advantage with these is the curves are very good, the curvature is very good, they're hydrophilic, okay, and they really work very well. So we've sort of gone away from the traditional Sarah catheter. I used a word before for these cannulations. We essentially use these catheters. So I had these catheters with me, so I decided to go in. The other question was, there's an ovarian, so there's an ovarian artery there, right? So there is some supply from the left side. There's no supply from the left side, but there's an ovarian artery. So should I embolize the ovarian artery? And then there's a lot of questions about ovarian failure, premature menopause, and this is not a forum to discuss about that particular aspect, but there are a few things I kept in mind. One is relevant history. So she was older, almost 70 plus old, very unusual for UFI population. So I said, she's got symptoms, she's got severe symptoms. I need to do something for this patient. She doesn't really care about pregnancy or menopause and stuff like that. So I took on the technical challenge and decided to embolize both ovarian arteries. Pretty difficult angulation. So I put that MG2 catheter there. I don't know if it's visible to you guys. Put an MG2 catheter and put a little curve on the wire, took a micro, and I hooked on into the vessel. So that was the left side. I went down the ovarian artery. It was a 2.4 prograde. I went down the ovarian artery and I put particles. And then I decided to go to the right side. The right side was even more difficult. So I sort of, tried to turn the catheter, and I finally got into the artery, and I went inside. And interestingly, this is an anomaly which I don't know what is this, but I saw this anatomy, and I was like, I don't know what is this. Started putting beads, and the patient had acute pain in the right side of the abdomen. And I stopped. I started again pain. I'm thinking that these are small ureteric branches. It looked like it was a lumbar pain. I don't know what it is, but I didn't really embolize this to stasis. I just embolized a little bit just to get enough relief. And she did well after the procedure, and I'm still following her up. I think it's about a year now. She's doing extremely well. So that's a difficult UFI. So let's go to a little different beast, which is PAE, right? PAEs are difficult procedures. The arteries are small, the angulations are different. You guys have heard a lot of PAE in the last few years, and even at SIR this year. But what is the challenge with PAE, and what is the solution to it? So one of the reasons that radial approach is used in PAE is because of this. So you see this is a CTA with reconstruction, where you see that we do CTS first, and then you see this angulation, right? So you see this is going to be a difficult procedure from the groin. Now, if you get bilateral femoral access, yes. But a lot of these patients may be an anticoagulation, stuff like that. So I think in these cases, a radial approach is very reasonable. It can really help you. And I've had some femoral to radial conversions in some of these cases because I had to go this way, sort of reverse. So what are the advantages of transradial PAE? You can up and over angles are better. You can go straight down like this. Again, bleeding risks. There are a lot of advantages of transradial in these cases. Elderly men on anticoagulation, bleeding BPH, and these are some of you are not doing PAE. These are some of your initial patients that are going to come to your practice. The urologist doesn't want to take care of these. These are going to come to your practice. So you need to be ready to handle this with all your radial tools. And then faster mobility post PAE. They can go home faster. They have no issues with ambulation and stuff. What tools do we have? And things have changed over the last few years. With respect to PAE, we don't have all the tools yet. We're still getting there because a lot of catheters are, you need angulation, you need maybe steerable catheters. There are so many things that are still coming out now. But we have gone a long way in the last few years. We used to do exclusively femoral, and I still do femoral PAEs. I'll be very honest. I still do a lot of femoral PAEs, but I select my patients. Transradial has a role there. Femoral has a role in some cases. So what tools do we have for transradial PAE approach? Use our regular 5-6 French glide cylinder sheaths, the short ones. Now, and I'm going to show this in the next case. Glide cylinder sheaths are also come in larger diameters. They go up to 119, 149 centimeters, which are the 119 centimeters is something that you can use for PAEs because it can give you a lot of good stability when you go down. the tortuosity. You can get rid of the tortuosity because you can sort of straighten the vessel with I use a glide advantage a lot to sort of stiffen it out. So there are options available now. In terms of target, guide wires, and catheters, I use the Benson, I use the Terumo glide wire, 0.035. Base catheters, I've moved from the Vert catheter and all those to the 4 and the 5 French MG2 catheters, which now come in 125, 135, and 150. I think a 150 will definitely get rid of the pelvis, even the guy who's 6'3", 6'4", and never had a problem with that. In terms of microcatheters, we do have two French microcatheters that come in different shapes now. The 2.0 ProGrade Alpha has been my go-to in the past so many years. You have 150 centimeters, and you've got shapes now that are available, which are very useful for PAE because it's an acute angulation sometimes. You may not need it for UFI, but for PAE, these are very useful. There's also the 1.9 French ProGrade Lambda, which is now 165 centimeters. So now you can use it with a 150 base catheter and a 165 microcatheter. There's almost no height contraindication now for PAEs. Okay, so this can be essentially used, and this has all come out in the last few years. This wasn't available many years ago. The ProGrade Lambda I'm going to show you in the next slide, but this is the new catheter that comes in different shapes. In terms of intervention, we use a lot of hydropole in our practices. For PAEs, I essentially start with 200 first, unless it's a huge prostatic artery. I start with 200 and then may go up to 400 if needed. Or if there's a collateral going down, I may start with the 400 itself there. So it's just to avoid non-target embolization. So those are essentially the size of the particles that I use. And then in terms of coil protection, there are various options now. And I know that probably some of you may know this, but remember that the 2.0 French does not take it only takes the CX coils. It does not take the Azure coils. Okay, so that's something that you should keep in mind because the tech often hands you that. Just take the CX coil if you're using a 2.0 French. If you use a 2.4 French, you can use the other system. And then in terms of compression, we use the radial compression band, as Dr. Gimenez spoke about. The ProGrade Lambda, it comes in various shapes: straight, 35-degree triple angle, 1.9 French, 165 centimeters. It's got an asymmetric, densely pitched, braided construction that really, you get good torqueability because, you do lose some of our torqueability when you're talking about various arches here, right? You're going through that, especially in older people, you're going through that arch in the aorta, the iliac bifurcation. So there is some amount of loss, but I think this catheter is great because it makes up for all those angulations. So it's really a great catheter to use for these procedures. So this is the tall PAE patient. Okay, he was 6'4", I can't remember, but I go down, and if you see that, I can show you. But, oops, what did I do? All right, the prostatic artery lies there, but the challenge is that now you have a branch that's going down. If you see that branch going down all the way, that's an accessory branch. Okay, that's an accessory pudendal artery that is supplying the pudendal artery which goes to the penis. So now if you're going to put particles there, so you can either go into the prostatic artery selectively, which is going to be a challenge because there's a lot of curves there, and it can cause spasm, right? A prostatic artery and uterine artery is not the same. A prostatic artery causes spasm right away. So you can go down there and cause spasm, but what I chose to do was I chose to actually go down there and put the CX coil, which is coming down now. So the CX coil went down there. I did protective coil embolization of the accessory pudendal artery. And then if you see that there's no blood flow going down there, and I got in, then the prostatic artery actually, it bulked up a little bit because now the flow was diverted towards the prostatic artery, and then we went and put the beads there. So again, in 2023, we have a lot of solutions to this patient. We have a lot of tools that we have to help these patients. Are we on time? Time for another case? Jen? Okay. Last, I'll touch a little bit about radial to peripheral for PAD-CLI. Again, a lot of things in evolution here. Are we there yet? I don't think we're there yet. But we're getting there. Once we start using these products, device companies see the interest and they start developing things for us. So it's our responsibility as our physicians also to push them to do this because this can be useful to your practice. So let's go through a quick case. R3 claudicant, tried medical therapy. claudication interventions are sort of looked down upon in this age and time. This was a case from about 2 or 3 years ago, but failed medical therapy. I put them on cilostazol, did not work, brought a patient back in 3 months, and then had to do a intervention on this patient. So initial angiogram, you see there, and I won't go into details in interest of time, but she had long segment SFA CTO and also had a mid posterior tibial artery CTO. Again, my aim was to open the SFA. I got access. Femoral not access due to high-placed kissing iliac stent. So there are certain indications in the peripheral arterial space where it is actually difficult to do femoral access. Kissing iliac stents, very tortuous vessels. Antegrade access is an option, but it's a flush SFA occlusion, right? So, and antegrade access will be difficult in this case. You won't have enough length to cross the occlusion. So, got left radial access, used the destination 119 centimeter glide cylinder sheath, which went all the way. And then I could not cross, right? So I could not cross the SFA occlusion. So the next thing we do is get pedal access. So I got a pedal access. I again used the glide cylinder. I used usually 5 or 6 French sheaths, depending on what stent I'm going to use, what atherectomy device I'm going to use. So I think I put a 6 French sheath in this case. And then next, I decided to cross the CTO. I had 2 Navicross catheters. Navicross are really good catheters from Terumo, which are 90, 135, 150. They almost work. They're supposed to be crossing. They work as good crossing catheters. They've got good tapered tips. So I got a Navicross from the top, from the bottom, tried to cross across. I was subintimal. Again, in the interest of time, I'll go through this quickly, but I used 2 balloons, what you call the double balloon cart technique. You put 2 kissing balloons, you sort of break the flap in between, and that's how you get interluminal again, right? So I got interluminal again, and then I sort of flossed across the whole body. This is a pretty nice case. I had 1 resident at the top, 1 resident at the bottom, and we were working through the whole case. And then, there are options now. There is a 035, 350 and 450 centimeter glide wires, and there is a wiper wire which is 014, I think, which is 475 centimeters. Decided to treat. There are options in atherectomy, but very few options still. I hope we can have more options in the future for these things. But I did atherectomy from the radial aspect. Did some of the SFA. Used a 200 centimeter shaft balloon from Terumo, and then I had to stent the patient. So I put Misago stents. These are great stents. They are rapid exchange, 200 centimeter length, so you can go from radial all the way down and stent in the SFA and the popliteals. Popliteal not as much, but definitely SFA. There is still drug-coated technology is still evolving in this field from radial approach. Covered stents are still not there, so you can have issues. So we are not there yet, but I hope in the future we get into this. There are more devices and options that we have in this space. So I did CSI. I also, I got access to the posterior tibial artery, so I said I'll treat it on the way out. So I treated on the way out with a balloon and got pretty good angiograms. Patient did well. And remember that this is going to be very relevant because, this patient had a lot of heparin, right? We give them, for a 3-hour procedure, they get 10, 12,000 units of heparin. You're always worried about closure now, right? Closure is so important. You can do a great case for 4 hours and you can just screw it up because your closure has not been good. So I think there's a role of radial to peripheral. I hope it evolves in the future. Yeah, thank you.